So we are starting our session. Just give me some time.
Ishan, you can stop presentation at present because she is going to.
Okay, sir.
Yeah, we are live now on YouTube. And a very good afternoon and a warm welcome to one and all present here. I am Devulina from Clearnet, and we are very much proud to be a part of this webinar as a digital partner. Clearnet is India's largest live digital CAB and doctors-generated medical content platform, which is exclusively free for all the medical practitioners. So now with all of you, I am going to share a short glimpse of Clearnet. Thank you so much, all the doctors, for your patience. Our website goes www.clearnet.com. There we have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors. That also you can read. In your leisure time, you can play books and quiz also on our platform. So now I would request all the doctors, please visit our website, which is www.clearnet.com. And now without further delay, I would like to hand over the session to Dr. Prashant Karia sir to start our today's video. Over to you.
So, good afternoon, everyone. On behalf of NNF Gujarat, I, Dr. Prashant Karia, Secretary of NNF Gujarat, welcome one and all. We do have our advisors, Dr. Somsekhar sir, with us. And the idea of Neonatal Pathshala is to present a case in which the postgraduate student will present a case and our experts will be actually guiding them regarding the case. Today we are having Dr. Kishan, who is going to present a case of neonatal AKI and peritoneal dialysis in it. And we do have two experts with us, Dr. Sheila Iyer ma'am, she is the professor of Baroda Medical College, and Dr. Jalpa Dave, she is a pediatric nephrologist. We do have Dr. Shwetal Bhatt with us. She is going to be a moderator for today's session. So without taking much of a time, I request Dr. Kishan to start with today's presentation. Yeah, thank you so much.
Good evening, all of you, respected teachers. Myself, Dr. Kishan Patel. Currently, I am working as a third-year resident doctor in Department of Pediatrics, SSU Hospital, Baroda. Today, I am going to present a case series of management of a newborn with acute kidney injury and review of AKI in newborn.
Is there any audio issue?
No, he's just presenting the screen, just trying. Yes. Debre, I'll send you the backup PPT if Kishan is not able to play.
Yes, I will do that. Let's try it once.
audio mute કરેલ છે
Fine, Kishan, it's full screen. You can start.
Yes, sir. Yes. Starting from history, sir. A full-term 37-weeker male child, 2.46 was birth weight. We have received with 1.96 kg. Weight loss was there. Appropriate for date. Male baby delivered at private hospital through normal vaginal delivery. Cried immediately after birth, and there is no history of any consanguinity. Referred to our EMNSU SSG hospital on 10th day of life with complaint of respiratory distress, poor feeding, and weight loss. As this was teenage pregnancy, baby handed over to an NGO, Godhra, at 24th hour of life. where routine checkup was done at hospital, and at third day of life, baby was discharged on exclusive formula feed. Now on sixth day of life, there is history of one episode of vomiting, and there is a refusal to feed, for which baby taken to the hospital where some OPD medications is mentioning tablet junior Lanzol given, and the weight recorded which is 2.2 kg, which is at General Hospital Godhra. And after that, on ninth day of life, baby developed respiratory distress, for which he was admitted at General Hospital Godhra. The weight on the ninth day of life was 2.04 kg, which was 400 gram weight loss in 9 days, which is about 18% weight loss. Management in form of IV fluids with O2 support, they have started, and they have also started the first line antibiotics. And there is management for 36 hours of treatment. And as there is increased respiratory distress and ventilator requirement was there, baby referred to EM and ICU for further management with prior informed referral. On receiving, vitals was baby's euthermic, heart rate was normal 150 per minute, respiratory rate was more than 60, so it is 80 per minute. So tachypnea was present, saturation was 92% on nasal prong support at 2 liter per minute, and sugar was normal, so euglycemic, but the perfusion was poor, that CRT is more than 3 seconds, and the NIBP, which is mean, was 28, which is lower side. So, and also on general examination, that tachypnea distress was present, pulses which was feeble, radial was feeble, and Downing score was 7/10. So severe tachypnea and respiratory distress, baby required immediately mechanical ventilator support. Also, the signs of dehydration was present. Dry mucosa, skin pinch was more than 2 seconds, shrunken eyeballs were there, lethargy, and also the breathing was acidotic breathing was there. No any pallor, icterus or cyanosis, which was not there. So from above the findings, my probable clinical diagnosis would be single full-term baby, 37-weeker, AFD, male child, virgin delivered, cried after birth, respiratory distress, required mechanical ventilatory support. And maybe first chances would be query septicemia with respiratory distress. Second thing would be query acute kidney injury, because that acidotic breathing was present and the dehydration was there. So might be acute kidney injury. Then it might be inborn error of metabolism, because that poor feeding, lethargy, and that tachypnea distress acidosis was there. So it could be inborn error of metabolism and electrolyte disturbances. So maybe hyponatremia or hyponatremia could be there. On receiving, we have done investigation. As we have received the child, we have started management in form of invasive mechanical ventilation, IV therapy, IV fluid therapy, etc. But I would like to emphasize the investigation reports, like the CBC report routines. CBC was normal, hemoglobin was 16.8, total count was 18,000, platelets were 4,22,000. So hemoglobin is normal. CRP report is 18, so sepsis was there, and the blood gas analysis report, which is a striking point. pH is 6.91, severe acidosis. PCO2 was 16.8. So CO2 washout was there. PO2 was 53, and bicarb is 3.9. So severe metabolic acidosis was there. Base excess was minus 20.7.7, and lactate was 1.0. So according to blood gas analysis, it was severe metabolic acidosis, and that RFT electrolyte report, urea is 166, which is hypernatremia is there. Urea is 166 and create is 4.3. So that is a acute kidney injury was there. Sodium and potassium, sodium is 157, so hypernatremia there, and potassium is 5.6, which is near normal. Ionized calcium was 1.4. So from this investigation report, we conclude that there are patient we have presented with acute kidney injury with hypernatremic dehydration with severe metabolic acidosis. And as there was significant acidosis, respiratory distress was present, baby intubated, kept on the mechanical ventilatory support. Now considering hypovolemia, because the dehydration was there, fluid loss was there, and CRT more than 3 seconds. So query septic shock component, we have given therapy like NS bolus, we have given at 10 ml per kg over 30 minutes, followed by second bolus, and later on IV maintenance fluid. We have started at 120% rate. So 1.2 times the normal value, we have started the IV fluid, maintenance fluid. And as there were fever pulses, even after NS bolus we have given and IV fluid, inotropic support in form of dobutamine we have added at 10 microgram per kilogram per minute. Minimal support we have added. And considering the sepsis and mechanical ventilatory support, we have started first an antibiotic, but single antibiotic injection piptas we have started. But after collecting the renal function report, injection levofloxacin we have added. And during this ongoing process, we have also monitored the vitals like heart rate, respiratory rate, saturation, then CRT and peripheries. We also monitor, and as well as urine output, because dehydration was there. So with catheter in situ, we are monitoring the urine output. These were required to track the improvement in patient's condition. Now, after 6 hours of management, the vein blood analysis, which is still not improving. pH was 7.02 from 6.9. PCO2 still washed out 11.8. PO2 was 91, but bicarb is still 3.0, which was on lower side. Base excess was -28 and lactate was 1.2. So considering pH and bicarb, still there is persistent metabolic acidosis. And second thing, there was only 1 to 2 ml. So just in tubing urine was there. So anuria type picture over 6 hours and persistent metabolic acidosis was there. Even after vigorous initial therapy, we have taken a call for renal replacement therapy in form of peritoneal dialysis. Now, peritoneal dialysis was done under all the aseptic precaution with proper explanation and informed consent of NGO's representative about the procedure and complication too. And prior the procedure, we have done the USG abdo-QB with suggestive of bilateral raised cortical echogenicity. The size of the kidney, which was right side kidney was 56 by 34 millimeter and left sided kidney was 50 by 32 millimeter, which was normal for the 0 to 2 month baby. That is a normal size of the kidney. And we have ruled out by USG the congenital anomalous for the kidney and urinary tract, in which the AKI presentation should be anticipated. This is the picture of a baby in which we have done the peritoneal dialysis after 2 days. After starting the peritoneal dialysis, we have started the bicarb correction because persistent acidosis pH was 6.9 to 7.0. We have started bicarb, soda bicarb correction. Required bicarb was 0.6 into body weight into deficit, which is the formula. Hence, we have given the bicarb with dilution in 1:1 with distilled water and given over slowly 48 hours. And as the urine output improved from 15 cycle of peritoneal dialysis, urine output was 0.5 cc per kg per hour, and peritoneal dialysis was continued for 40 cycles over the 2 days. And as once the UOP was established, 1.3 cc per kg per hour, along with that is improved metabolic acidosis with bicarb level was 18 in the blood gas. Also, there is the respiration was settled down. We have discontinued the peritoneal dialysis. After 48 hours of this mechanical ventilatory support, we have stepped down. We have followed the step down approach, and patient was made on off O2 at 3rd day of admission. Now on vitals, which was on 5th day of admission with RFT electrolyte reports, that vitals was quite normal. Euthermic, euglycemia was there, UOPs was adequate, weight was 2.5 kg, and the report RFT electrolyte reports which was improved. Sodium was 134 potassium is 3.5, urea is 14, and create is 0.87. And that blood gas analysis, which is also improved, that pH from 7.0 to 7.38, which is acidosis improved. PCO2 was 39.4 and PO2 is 67, where bicarb is 18. So bicarb improved after correction with peritoneal dialysis, and base excess was minus 6.8. And we have also done IEM workup to rule out IEM, but as plasma ammonia value, which were normal, which is 133, and baby's clinical condition is improving, lactate is also normal after correction. So we have not sent the sample for TMS study. Now, our next plan for the management is, first is to increase the feed and shift the baby to the full feeds. And second thing is to complete the antibiotics, because all the septic strip we have sent initially, in which blood culture report suggestive of corn sepsis, we are continuing antibiotic for 14 days, which was sensitive antibiotics. And third thing was that complete all the workup for an orphan baby, because later on the baby was go for adoption. So all the workup for the orphan baby we have done, and the vaccination, which is important, vaccination and the OA screening or SOS Beta test should be advised on follow-up, and that proper follow-up should be there to prevent the future complication, as AKI in neonate period will also treated patient lead to the complication in later stage, like chronic kidney disease or hypertension or some other anomaly, some other complication. So the proper follow-up should be provided to the baby in the DEIC center for further prevention of the complications. Now, peritoneal dialysis, I would like to give some idea and the criteria for acute kidney injury classification in neonates. Peritoneal dialysis, which is an optimal renal replacement therapy in neonates who have acute kidney injury, and it is very safe and effective renal replacement therapy in management of a neonate with acute kidney injury. First of all, the KDI-GO criteria, kidney disease improving global outcome criteria. According to this criteria, the stage 1, 2, and 3, they are mentioned with serum creatinine as well as the urine output of the baby for classification according to stages in KDI-GO criteria. If the serum creatinine was 1.5 to 1.9 times increase from the baseline, or there is sudden increase of 0.3 milligram per deciliter within 48 hours, with urine output was less than 0.5 ml per kg per hour for 6 to 12 hours, that will come under the stage 1. And stage 2, the serum creatinine, if it is more than 2 to 2.9 fold from the baseline increased, or urine output is less than 0.5 ml per kg per hour for more than 12 hours, then the baby could be kept under stage 2 or stage 3, serum creatinine, which was threefold increase from the baseline, or increase in the serum creatinine, which was equal to or more than 2.5 milligram per deciliter, with an acute increase of 0.5 milligram per deciliter, or whenever the baby required renal replacement therapy, should placed under the stage 3, or urine output, which was less than 0.3 ml per kg per hour for or equal to or more than 24 hours, or complete anuria was there for equal to or more than 12 hours, should be placed under stage 3 as per the KDI-GO criteria. There are also two different criteria like acute kidney injury newborn criteria and neonatal rifle criteria, which were used. I would like to describe the AKIN criteria, in which the stage 1, 2, 3 they have mentioned with serum creatinine and urine output of the baby. Serum creatinine, which was 1.5 fold rise from the baseline or equal to or more than 0.3 milligram per deciliter within 48 hours, should be considered as stage 1, along with urine output less than 0.5 ml per kg per hour for equal to or more than 6 hours. Stage 2, that serum creatinine, if it is two-folded rise from the baseline along with urine output less than 0.5 ml per kg per hour for equal to or more than 12 hours should be considered under stage 2, and stage 3, that serum creatinine, which was threefold rise from the baseline or increase in the serum creatinine to more than or equal to 4 milligram per deciliter, with an acute increase of 0.5 milligram per deciliter, or whenever the baby required renal replacement therapy should be placed under stage 3, along with UOP was less than 0.3 ml per kg per hour for equal to or more than 24 hours, or anuria for equal to or more than 12 hours. Whereas neonatal rifle criteria, which suggest that is a short form, that is a rifle, risk, injury, to failure, then limitation, and end-stage renal disease, which include the serum creatinine along with urine output and duration, specifically in neonates. Serum create if it is more than 1.5 times, along with urine output less than 1.5 ml per kg per hour after 24 hours should be placed under a risk, and serum creatinine which was two time higher side, and along with urine output which was less than 1 ml per kg per hour after 42 hours, which also considered under the injury and the failure. So serum create which is 3 times higher or more than 4 milligram per deciliter, or there is along with urine output less than 0.7 ml per kg per hour for for more than 24 hours, or is there is anuria for 12 hours should placed under the failure, risk, injury, and failure. The last two stages was limitation. If there is a loss of kidney function for more than 4 weeks, so about for a 1 month, the kidney function loss there should be kept under limitation, and the final was end stage criteria, that loss of the kidney function for more than 3 months should be kept under the end stage disease. So this rifle criteria, AKI criteria, and KDI-GO criteria, these 3 criteria normally are used in this practice for neonatal management of neonatal acute kidney injury. Indications for the peritoneal dialysis. There are different indications for peritoneal dialysis. First is the if there is an electrolyte abnormality in form of resistance hyperkalemia, when the hyperkalemia cannot be managed by the different method like intravenous calcium gluconate or potassium binding resins, or whenever there is a we cannot control by glucose insulin infusion drip, so we should go for the peritoneal dialysis to treat the hyperkalemia, as the soda bicarb will lead to the hypokalemia and reduces the serum potassium level. Second thing is oliguria or anuria. When there is a urine output was less than 0.5 ml per kg per hour for more than 6 hours, or if there is a anuria, no urine output for more than 48 hours, the call for the peritoneal dialysis should be taken. Third one is the persistent metabolic acidosis. If the child has metabolic acidosis and the breathing was acidotic after giving bicarb correction, still it is not improving, the peritoneal dialysis should be done, and the bicarb correction should be given along with the peritoneal dialysis to improve the acidosis and treat the metabolic acidosis along with the bicarb correction. Then inborn error of metabolism. Sometime when the child presented with poor feeding, lethargy, convulsion, the feature for IEM workup, and if the ammonia was higher, which is more than 350 or higher side, the peritoneal dialysis should be used as a measure to remove the excess, the toxic component through the renal excretion. So for IEM, it can be used as a to remove the solutes, to toxic solutes. And the last one is the requirement of blood products along with the AKI in neonate. If the child has anemia and along with dehydration and acute kidney injury, if we want to give the PCV, that red cell concentrate, we have to introduce renal replacement therapy, and the PD is very safe and easy method. So it can be introduced to give the packed cell volume in a neonatal anemia. Now, some preparation about the patient preparation. There are two: patient preparation and equipment preparation for the peritoneal dialysis. First, patient preparation. We have to explain the procedure and obtain the informed consent, because peritoneal dialysis is an invasive method and it can lead to some peritonitis as a complication, or sometimes there is injury to the bowel, or that might be the some other problem later on. So we have to inform all the that indication, advantages, disadvantages, and taken the prior written consent from the parents or the guardian or the NGO's representative. And then baseline vital signs, weight, routine investigation should be recorded before the starting peritoneal dialysis, as it must be required. Like we have to monitor the serum electrolytes 6 hourly or 12 hourly, along with the urine output, which is a indicator to withhold the PD. Whenever the UP was established adequately, with we have to repeat the blood gas analysis for minimum 24 hours to check for the correction of acidosis along with the backup improvement. So this all patient preparation we have to done. Second is equipment preparation. Assemble the equipments needed, like PD catheter with trocar, PD dialysis set, and the peritoneal dialysis fluid, which was known as IPD, intraperitoneal dialysis fluid, and the cannula. So I would like to say the this instrument which we are using for the peritoneal dialysis. First one, that is a scalpel, which we are using to make a nick at the access site before inserting the that catheter with the corkscrew movement. So for these, so this instrument we are using for making a nick. Second is the peritoneal dialysis catheter set. This plastic dialysis catheter set we are using after inserting the catheter and attaching it with the three-way assembly to drain, to fill in and to drain the PD fluid. And the third one is the peritoneal dialysis catheter, which was made of silicone, and there is a fenestra over 2 to 3 centimeter initial. There is a fenestra through which the fluid will get filled in the peritoneal cavity, and there's an exchange was done, and later on from this fenestra peritoneal dialysis catheter. And the last one is a PD infusion set, which is a three-way set from which the fill-in process and the drain out process we are doing from the SAM. There is a single controller through which we are doing the peritoneal dialysis step by step. This is the IPD fluid, the intraperitoneal dialysis fluid, which is also an important for the management of the peritoneal dialysis and the ultrafiltration. Normally, the IPD fluid, which contains the dextrose anhydrous solution, which are in different concentration, which was 1.7% or 2.5% different concentration. If there is a fluid overload or fluid overload, and for which if we do the PD, then the concentration of dextrose should be kept higher side, so that the ultrafiltration was done and the solutes or the fluid which can remove from the osmosis. And the IPD fluid contains sodium chloride, sodium acetate as a buffer, not a bicarbonate. So acetate will convert into the bicarbonate in the liver, and after that the bicarbonate, which is a physical buffer, which will going to be improved. And also calcium and magnesium was the component of the IPD fluid. There is lack of potassium, so IPD fluid does not contain potassium. So potassium monitoring should be done every 24 hourly or 12 hourly in the patient in whom the peritoneal dialysis was ongoing. Now I would like to narrate the PD procedure in a short. the access site. First of all, the access site should be just below umbilicus or just lateral to umbilicus, the either of the flank side. From umbilicus to the catheter direction downwards toward the pelvis to right or left of the bladder. And the bladder should be emptied first after inserting the catheter to remove the injury during insertion of trocar to the throughout the peritoneal space. So that is the point we should be kept in the mind, that the emptying of the bladder should be done first. Second thing is the painting and draping, which we will done for the aseptic precaution. Now, the main point is the priming. Priming is a process in which we are separating the two space, which is the parietal peritoneum and visceral peritoneum, by filling the fluid to create a space where the ultrafiltration was taken. Ultrafiltration will take a place. And infant and neonate have more space for the exchange or for the ultrafiltration than the adult. Priming should be done using intravenous cannula of 24 gauge size and filling of the that space with normal saline at 15 ml per kg till we can feel the ballotment of the abdomen, so that will be a space created between two, that visceral peritoneum and parietal peritoneum, and we can easily insert the catheter and fix the catheter with fenestra kept inside the space to for the performance of the ultrafiltration. Now, tiny incision.
Sorry to interrupt, Kishan. So, is it this fixed value like 15 ml per kg, or you can kind of use more fluid or something like that for priming? Is it the fixed amount you need to insert?
Ma'am, actually, for priming, we can give 50 ml per kg or 20 ml per kg, ma'am, till the ballotment. Because if we filling the more fluid, it will cause the respiratory distress or respiratory that distress should be to the patient, ma'am. So the priming should be at least 50 ml per kg, ma'am, till we can feel the abdomen was ballotment, and we can feel that insertion of the catheter should not be going to injure the viscera or any the peritoneal that peritonitis or other complications should not be anticipated.
Yeah, very correctly answered. So there is no fixed value. You know, if the patient is situs or something, then even with 10 ml of kg, you will have adequate fullness of flank and you can insert. But you know, sometimes if the patient is too thin and you are not getting enough fullness of flank, even with 15, 20. So as long as while you are doing this priming, while you are inserting, that you need to keep monitoring respiratory rate and SpO2. So if there is kind of tachypnea or desaturation occurring, then you should stop. Otherwise, sometimes you can go as high as say 20 to even 30 ml per kg, because it's very important for you to have that fullness of flank. Otherwise, you can injure your bowels. So depending on your own patient, and as long as you are comfortable, like if you feel okay, still the fullness of flank has not achieved, then you can also go as high as 30 or even 35 ml per kg, as long as there is no tachypnea or desaturation or signs of that increased intra-abdominal tension, right?
Yes,
okay.
ma'am.
Okay.
Ma'am, now the tiny incision should be made, or there is a step, or there's a nick we had to make at the access point before inserting the catheter. So we can pierce the skin, which is a thick, and later on we insert a catheter, and towards the direction, just right or left to the bladder, using the corkscrew movement, and we will stop when we feel the loss of resistance, and we now enter in the that is space which we have the separated by inserting the fluid. And now we will fix the catheter after we will confirm that all the fenestra are in the created space, and we will attach the assembly. We will fix the peritoneal dialysis catheter, and now onwards we are starting the PD peritoneal dialysis with infusion set, and go with the 3 steps, which is filling, second is dwell, and third is drain out. Now, first is the fill-in process. Fill-in process which takes 5 to 10 minutes, and we will fill the IPD fluid, intraperio dialysis fluid, in the space with 10 to 15 ml per kg volume for each cycle. Volume can be increased up to 25 to 30 ml per kg. And larger the filling volumes should be avoided because it may causes the pericatheter leak or respiratory compromises. And second step is dwelling time. Dwelling time is the important step in the management of the AKI as a peritoneal dialysis, because during dwelling time, that solute removal, the ultrafiltration, this all process are taking place. So dwelling time should be ranges from the 30 to 40 minutes. The shorter dwelling time exceed the urea. So dwelling time we can fix shorter duration for removing the urea, or we can take longer time for dwelling time to use the ultrafiltration as a maximum support. So maximum ultrafiltration, we can use that more dwelling time or short dwelling time. So, and the third part was the drain. So third step is the drain out. So IPD fluid should be drained by the same catheter, as it was a three-way catheter, and it takes 8 to 10 minutes to completely drain the amount of the fluid which were filled in the step. Or sometimes it may take a little longer time, because sometimes there may be a obstruction in the catheter. So it might take 8 to 10 minutes or 10 to 15 minutes for the draining of all the fluid, IPD fluid, which were exchanged there. And we are doing the rapid cycles, 5 to 6 cycles without dwelling time. So we are doing rapid cycles, 5 to 6 cycles. And after that, we will start the slow cycle, which was a normal PD cycle, which is of about 1 hour. That filling time takes 5 to 10 minutes, then 30 to 40 minutes time for the dwelling time, for the exchange of the solutes or toxic substances in the peritoneal cavity. And lastly, the drain out time, which was about 8 to 10 minutes to remove the waste substances. And after that, we will start the next cycle for the peritoneal dialysis for the second cycle. So about 1 hour cycle is there for peritoneal dialysis in the newborn. And second thing, that is this as this is an invasive procedure, and sometimes chances of sepsis there, we are added antibiotics, different antibiotics, sometimes piptas, sometimes cefosalectam, sometimes metronidazole in the IPD pint, as this is invasive procedure. Sometimes may lead to the sepsis like peritonitis and other complications. So to reduce the complications, we added the antibiotic prior in the IPD fluid. And as discussed earlier, that the peritoneal dialysis pint, the solution not containing the potassium. So in some patients, we have seen that there is a complication like hypokalemia was there. So we are inserting that potassium chloride injection 1 ml in 1 liter of PD pint after 24 hours of peritoneal dialysis with that continuous monitoring of the potassium to reduce the chance of hypokalemia. If we are doing the peritoneal dialysis for the hyperkalemia, we are not going to add the potassium chloride. But if we are going to do the dialysis for the persistent metabolic acidosis or some other indication, we can add the injection potassium chloride at 2 MEq in 1 liter PD pint. So 1 ml contain 2 MEq of potassium chloride. So 1 ml we are adding in the PD pint of 1 liter.
How much maximum potassium you can add in 1 PD pint?
Yes, ma'am. Ma'am, 3 to 4 MEq, ma'am. I have read that 3 to 4 MEq of potassium we can add in a 1 liter of PD pint. And with proper monitoring, with considerable monitoring of the potassium 24 hourly with renal function report, RFT report, to check for the hyperkalemia or still hypokalemia was there or not. So monitoring of potassium should be there, because sometimes cardiac condition should be precipitated if we forget to monitor the potassium, or hypokalemia or hyperkalemia if we miss the electrolyte disturbances.
Yeah, right. So maximum you can add is around 2 ml of potassium chloride, that is 4 MEq in 1
4 MEq.
And
Yes,
Yes, yes. Okay, you finish, then we can discuss regarding this PD prescription. Yeah.
Yes, ma'am. Now the when to stop the PD. Normally, PD we can stop when there is adequate urine output established, along with the correction of acidosis in the blood gas analysis picture. And second, it must be stopped when some complications we will see in the follow-up, like peritonitis, or which was redness over the insertion site, or sometimes there is a pericatheter leakage, or sometimes there is a bleeding from the site, which was more complicated. So we have to stop the PD when such complications should be there. So PD can be stopped at these two indication. And then now complications of peritoneal dialysis. The first is the blockage of the catheter, because we are inserting the catheter through the peritoneum. So sometimes fibrous tissue or sometimes omentum might be blocking the catheter. So that proper fill in and proper drain out should not taking place. And if we miss the some cycles, some peritoneal dialysis cycles that create and the backup, which we are which will not improve as per our expectation. So one is the blockage of the catheter, which was by momentum of fibrous tissue. Second is pericatheter leak. If we inserting a nick, we make a nick and insert the catheter. If sometime nick was somewhat larger size, that catheter leakage should be there. So on sometime if we fill in the fluid, which was more than the required one, it will cause the leakage from the inserting side. So it should be kept in the mind that the nick should be made only we can insert the catheter and we can fix the catheter, and that fill-in fluid should be minimum to continuously check for the leakage of the fluid from the pericatheter area. And third one is the peritonitis, which is very dangerous complication, because if during the insertion, if we have not done the priming with proper fluid, and if we insert the catheter, it will sometimes cause the injury, direct injury to the bladder, or sometimes peritoneum, or sometimes that bowel. So perforation or peritonitis should be there, and it is a very which is complication of the PD. So it must be kept in mind that proper fill-in process should be there, and proper priming should be there to make the to create a space adequately to insert the catheter. And the fourth is the misplacement of catheter. Sometimes that when we have fixed the catheter, sometime 1 or 2 days after, it might be get misplaced. So which is a complication. We have to refix the catheter, or sometimes we have to reinsert a catheter to other side to prevent the misplacement for further peritodialysis outcome.
Is there a way
And,
you? Yeah.
yes, ma'am.
How will you define peritonitis? Like, how will you come to know if the patient has developed peritonitis or so?
Ma'am, first of all, that vitals, ma'am. We are continuously monitoring vitals as the child is in the ICU. That tachycardia was there, or sometime from the general examination, like redness over the pericatheter redness. Sometimes there is the fluid which is coming out, to the drain out, which sometimes, ma'am, hemorrhaging. So it will give us a idea that might be a perforation. Sometimes we will get done the point of care USG, ma'am, to check for the perforation. Is there is a perforation or free fluid, or sometimes hemorrhagic perfusion fluid there or not. So from all this, we can get an idea that there may be peritonitis, there is high count. Also, we can, ma'am, go with the PD fluid analysis, ma'am, which is important. That PD fluid we are draining out, we should send the sample of the PD fluid to the laboratory for routine micro of the of the PD fluid, in which if there is more than 50% of neutrophil is there, so it's suggestive that this is a peritonitis, and there is increase in the then we can also send the culture, ma'am, if there is a sepsis or other complications are there. So, ma'am, PD fluid analysis should be kept in mind. If there is a peritonitis, there is more than 50% of the cells are going to neutrophils, ma'am, in PD fluid.
perfectly said. So PD fluid analysis is very important. And you
Yes.
know, actually what catheter we are using as stiff catheter. So
Yes, ma'am.
should not use it more than 72 hours. You know, otherwise there are more chances of developing peritonitis. But if in case you need to use this catheter, say more than 72 hours, then you can send this PD cells, like that PD fluid analysis which you are talking about. And that it is showing more than 100 cells with more than 50% of polymorphs, then it's an indication that, you know, it's better to remove the PD, give rest to the peritoneum. You can like take help of your diuretic for a, say, for a day or two, and then reinsert the PD. So because the
Yes,
stiff
ma'am.
catheters are very prone for developing the peritonitis, that soft tank of catheter are very expensive. So we can easily use this stiff catheter, but if if you had to use it beyond 72 hours, then better to send PD fluid analysis to know. And ideally, more than 5 days, you need to remove. Give rest to the peritoneum, say for a day or two, and then if required, if your child has still not recovered from AKI, then you can kind of reinsert the same thing.
Yes, ma'am.
Okay. And regarding leakage, so one point to prevent that too much of pericatheter leak is sometimes you can avoid making that leak, you know, with that knife or nick you are making. So especially in newborn, with the help of that catheter itself, you can make insert that catheter directly. So either make sure that you are making that nick very tiny, or else if the baby is otherwise okay, the skin is not very bad, then you can directly insert the catheter so that the pericatheter leakage problem won't be that often with this technique. Okay, good.
Yes, ma'am. Sure. Now, ma'am, contraindications for the peritonitis, ma'am. One is the before peritonitis, we will do all the routine tests, ma'am, like coagulation profile. If there is abdominal coagulation profile or sometime the patient with necrotic enterocolitis, or in patient when there is a stoma or that is surgical patient in which there is a renal function altered, we cannot do the peritoneal dialysis as there is an open stoma in the surgical patient or coagulation abnormality there. So it might be if the peritonitis or there is injury to the bowel, it will cause to bleeding and will lead to succumb of the child. So, and the sometimes anomalies like the hydroureter or hydronephrosis, if we miss before inserting the PD, if we have not done the USG, abdomen or KUB, it should be going to be deteriorated child. So these three are contraindication that coagulation abnormality, that necrotic enterocolitis picture, or surgical patient who have a stoma, or sometimes that hydroureter or some other anomalies. We should not introduce the peritoneal dialysis in the patient.
Just a
Yes.
minute.
Yes.
Kishan, it won't be an absolute contraindication of hydronephrosis and hydroureter. Is it right, Jalpa? Because
yes.
we have received a patient of obstructive uropathy where to overcome the acute crisis, after
Yeah.
doing the ultrasound, we need to do a peritoneal dialysis. So absolute contraindication will be only coagulation abnormality and necrotizing enterocolitis. Okay?
Yes. And even
Yes.
with
Yeah, probably. And again, your insertion of catheter and all has to be ultrasound guided when you have underlying anomaly, so
Yeah.
that iatrogenic complications can be prevented.
Yes, yes. And even with coagulation abnormalities, if the child like definitely needs and there is no other way, with FFP cover, you know, if the one who is very trained, an expert can do PD with coagulation abnormalities, because once you insert the catheter, there is no more risk. You know, so just the way like in spite of deranged PPINR, we do insert central lines. So sometimes if there is no other way to do the renal replacement therapy, with good FFP cover, if you are very sure that you will be able to get it in the first prick itself, you know, you can do peritoneal dialysis in even coagulation. But yes, NEC is definitely an absolute contraindication, and any like gastrocrisis or any such kind of intra-abdominal pathology related to bowels. But as ma'am rightly said, hydronephrosis, hydrouretic, what you can do urinary catheter first. So that's how you will drain the system, and there are less chance of perforating your too much hydronephrosis or hydroureter. So rightly said, it is not an absolute contraindication. Yes, yes, ma'am.
Now outcome of the peritoneal dialysis. Now we have experience of a 15 peritoneal dialysis patient in our neonatal ICU over 6 months for different indications. For better outcome seen when the patient have AKI component with hypernatremia, hypernatremic dehydration, in which peritoneal dialysis has better outcome, while the AKI component due to severe birth asphyxia or a child has multi-organ dysfunction syndrome. The PD we are doing, but the outcome was very poor. This is a table. Over the 15 patients, AKI with hyponatremic dehydration, we have total 10 patients in which we have done the PD, and out of which all the patients survived. No expired. And second is inborn error of metabolism. There is one patient in which we have received with the poor feeding, shallow respiration, and there is hypoglycemia, and there is a liver that hepatomegaly was there. So in this patient, after collecting the renal function report, as the creatinine was higher side and hyperammonemia was there, ammonia was more than 350, we have inserted the peritoneal dialysis to the patient. But later on, the child expired because there is a severe birth asphyxia was there. And but TMS report we have sent which suggestive of hyperprolinemia. And the third indication was multi-organ dysfunction syndrome due to severe birth asphyxia. Number of the dialysis is 4, in which all the patient couldn't survive now because that the renal component and then CNS system, renal system, and the PPHN was there. So all these multi-system involvement, so patient not revived. But the good outcome are seen with the patient who have hyponatremic dehydration. We can surely manage the persistent acidosis along with the hyponatremic dehydration. So at the end, I would like to give a take-home message is that early identification of acute kidney injury after an optimal fluid therapy and timely implementation of the renal replacement therapy leads to a successful outcome. And this is orphan baby, which we have received with the metabolic acidosis with the severe metabolic acidosis with hypernatremic dehydration, kept for the 2 days on mechanical ventilator, and gradually we have inserted the petodialysis, and we have managed the child very well. And currently, child is on full feeds and tolerating the formula feed well. And we are planning to discharge the patient as soon as we complete all the formalities.
At this juncture, as this is a baby who is going to be later on made fit for adoption, I think I would want our experts also to comment about, because we would be required to counsel the adopting parents with this stormy course as far as what is the renal prognosis that we should be talking about to the adopting parents.
Yes, ma'am, definitely, because as we all know, like now more and more data and more studies are confirming that neonatal AKI do have a kind of stormy outcome even later on in life, but one thing is definitely there, we need to monitor the urine protein creatinine ratio, what we see, as well as serum creatinine, along with the blood pressure monitoring. We can also do DMSA scans, say around 2 or 3 months of age to kind of prognosticate. But still, I would say it's very difficult to give them a clear-cut, clean chip that, okay, the baby is completely out of danger. So even if our DMSA scan, say at 3 months, comes absolutely normal, we don't know how much hyperfiltration injuries and other things have occurred to this baby. So, legally, to give a clean chip that this baby won't have any renal consequences in future is a bit difficult. But yes, we can definitely say that if we kind of monitor the baby with a regular follow-up, blood pressure monitoring, and kind of proteinuria thing, then and avoiding nephrotoxic medication in future as well, then definitely the baby will have a very good survival and outcome.
Because this forms a very important prognostication, especially because otherwise child gets stigmatized and
Yes.
would not be, I mean, picked up for adoption. So proper counseling and follow-up both would be required. I entirely agree with you. But
Right.
this is again one more thing when we say long-term intact outcome, this kidney injury is also an important organ, which one
Yes.
will have to look at it in the follow-up.
Yes, yes, ma'am.
One of the other things, because though AKI is a commonest complication of many NICU admissions,
Right, right.
the amount of renal replacement therapy being done probably is, if we look at the data, definitely is less. So somewhere probably using the all neonatal AKI criteria and NICUs getting more expertise in doing peritoneal dialysis would go a long way in early intervention.
Yes, yes, ma'am. Yeah. So, and it's very nice to pick up neonatal AKI, because as we also saw in the criteria that oliguria, neonatal AKI won't always be oliguric. Many a time they are non-oliguric. So it's very
Yes.
pick up the subtle signs of impending kidney injury and act accordingly. Like before we have a frank renal failure and raised creatinine. So because oliguria is something very last to develop, especially in neonates. So that's what. I
As
just
such,
yeah. No.
as such, there are no questions on the chat box, but we would like to, Sheila, ma'am, can you share your experience of different etiology, what you have
I think
experienced and the outcome? Because you have a long
outcome wise, as this was the discussion which I had with Jalpa. Unfortunately, though we call off all those our neurodevelopmental follow-up, kidney yet hasn't been given of that much of importance for the NICU graduates. I think we need to include hypertension and renal functions, because a lot of new literature coming up with our IUGRs, low AFI babies getting delivered, though they are not having AKI in neonatal period. Before the age of 5, many of them are manifesting with renal manifestations. So other than the obstructive uropathy also, I think we need to give more importance to at least all those who are at high risk. There should be a periodic follow-up of renal functions, picking them up early, and then probably our use of renal toxic antibiotics. We need to be, it's that those who are borderline are going to get injured more. As far as doing peritoneal dialysis, I was the other day also discussing that first time we did in a newborn with severe birth asphyxia was way back in 1993.
Oh.
So it's been, and again, the outcome wise, as what within 6 months, Kishan tried to say as part of his thesis that with birth asphyxia, though more than 50% have renal injury, that's not the only injury. And that's why the outcome is dependent on many. But like we saw that pre-renal, which becomes renal like in hypernatremic dehydration or any sepsis and dehydration, if we do a renal replacement therapy, the outcome would be better. So I think all those who are looking after such babies, I think one should, with all the criteria, it's very easy to pick up at what stage we require renal replacement. And we should be doing it early. So probably, maybe the long-term outcome is better. What would you think, Jalpa?
Yes, ma'am. It's like properly managed and kind of intervened at the right time, then it would be definitely. And what I would like to say is fluid management is really, really very important. Sometimes if we
Yes, definitely.
So sometimes if we do a proper fluid management, then we can kind of avoid renal replacement therapy. But at the same time, you should be very vigilant that, okay, this is the end point. Now the baby is not going to respond to fluids, and you need to start ahead with the kidney replacement or renal replacement therapy. So
one more thing, probably here again, I will put it as a red flag that, see, all of us have this idea of any baby who comes sick unless proved otherwise is septic. So we all start with antibiotic and aminoglycoside are a part of the component. So a kidney which was already damaged, we put a final nail on it.
yes, ma'am.
So we do have to be very, very careful while using nephrotoxic antibiotic, have a baseline renal biochemical functions, and one more thing, well diluted, slowly given aminoglycosides.
Yes, yes, very like what I prefer is to give them over 1 hour in infusion if required, especially in newborn.
Yes, yes. Nowadays with infusion pumps available, I think aminoglycoside should become an indication that no boluses are given. They are given, or they are very well diluted and given in a small micro boluses when you are trying.
Yes. And the presentation of all this hypernatremic dehydration baby is very much similar to septic baby. So many times we are so from inside, no, there must be so much of sepsis. Let's start with 2 antibiotics because all the signs and symptoms will be kind of prompting us to let's start with another.
This red flag, I think, as a neonatologist, we should keep in mind because we might damage the kidney, though we might get the baby survived. We're going to leave him with something which is going to be chronic.
And you know, ma'am, with each 1 kg increase in babies like newborn, especially for all those preterm, with even 1 kg weight, almost 2 lakh nephrons are being formed. So, you know, all the IUGA and very preterm, we are having so many less nephrons compared to their term counterparts. So, especially all preterm IUGAs are very susceptible. And indeed, ma'am, very well managed case presented by Dr. Kishan and guided by you and Shwetal, ma'am. Just one to this thing, ma'am, regarding this intubation in metabolic acidosis, like the threshold of mechanical ventilation. You know, that's what even I keep telling my residents that sometimes if your chest X-ray is perfectly fine, if your chest is clear, there are no cracks, the baby is having purely acidotic breathing, then don't jump on to intubating him because all those acidotic breathing require very high minute ventilation kind of ventilatory settings. And sometimes we are not able to provide it. So just give them a chance, give them fluid, etc. Sometimes what they do with such a breathing, they will directly in emergency room only they will intubate. But especially those who are definite having signs of severe dehydration with acidotic breathing, with otherwise okay, completely clear chest. So don't go directly only by the score. If you feel you can manage this child with fluid, just give him some time. And if fluid and other therapy, the child doesn't improve, then definitely you should go ahead with.
Here there is a catch
True,
question.
but there is
What happens is a baby who is in hypotension, who is in shock. A
You cannot
supportive
wait.
ventilation is what I would recommend because we are very much worried with severe acidosis. There is already a CO2 washout, and severe hypocapnia is an indicator that I'm going to develop a PVL. I am going to suppress the respiratory stimulation, and till I get the child stabilized on volume, on his hemodynamic stability, it is more of a supportive ventilation, not actually a corrective ventilation.
Completely agree. If Jalpa, I would not have this child on mechanical ventilation. The child almost on a gasping phase and the child will go in arrest. So this severe metabolic acidosis has a severe myocardial injury also and almost in the bradycardia. So this is what is a supportive ventilation. Very minimal.
No, for this kid, definitely, like it will be definitely individual patient basis. If the patient is having signs of myocarditis and you feel that it is very
Your
long,
point for the elder babies are really well taken.
And
but for the newborn, no, we have a very small
supportive ventilation and should be that minimum duration.
Yes, ma'am. Happen that
because washing out further CO2 and being really aggressive on ventilation should not be the main.
Perfect.
Point well taken. What you are saying, and as soon as you see a child with respiratory distress, the immediate reflex is intubation. But again, sometimes it's required when you are transporting the baby.
Yeah,
Because
yeah,
a baby coming from Godra or Dahod, whether it is metabolic or whether it's respiratory, airway with a tube in gives a better chance than to have an arrest in the ambulance.
yes, ma'am. And
Jalpa, any early biomarker would you like to suggest
yes,
for,
ma'am.
like, say, in a birth asphyxia, what happens, no? To pick up a AKI in a birth asphyxia, most of the time we are late because the actual downfall starts at 4th to 5th day of life in birth asphyxia. It's a part of multi-organ failure. So, any early biomarker you would like to suggest for early picking up of AKI?
Ma'am, there are few biomarkers, especially this urinary biomarker like KIM, that kidney injury molecule, and especially this ANGEL, that nitrofiltratinase molecule. So they're very much in vogue, and especially in Western countries, they are kind of using this very frequently. But it's not that frequently available even in Mumbai and other parts of India. But one thing I would like to see is proteinuria, especially this microalbuminuria. That is very easily available. It is one of the earliest indicator to know your kidney injury. Along with your day-to-day round should be including the weight again. If you are feeling that.
Yes, yes. Clinical is fine. And what about cystatin C?
That is also one good biomarker, and especially when this aminophylline, what
Yes.
they say, that single aminophylline.
Yes, yes. Well, that is for birth asphyxia. Or do I recommend for all the patients who come with AKI?
No, ma'am. That is for
Only for birth asphyxia, right?
mechanism.
Yes. Yeah. Yes. That we definitely, we have already done a study for that, and it's part of our protocol to give aminophylline to a patient coming
I would
with.
just
Yes.
add a point to all our young PGs as well as our fellows that neonatal AKI is a very important component. We should be anticipating it, and our routine management of any high-risk newborn should include it, and a long-term follow-up of also of this patients as far as kidney injury somewhere needs to be registered, and a registry made probably will go a long way before we really learn more about it, how it has a long-term impact.
Yes, true. Yes, ma'am.
Okay.
Yes, Prashant.
Yeah. So thank you so much on behalf of NNF Gujarat, and it was really a wonderful discussion. So, Deblina, can we have the PPT?
Sure, sir. I'm sharing. Just a minute, sir. Making it full screen. Just a minute.
So, on behalf of NNF Gujarat, this certificate of appreciation is presented to Dr. Shwetal Bhatt for moderating the PG case and guiding Kishan for presenting a case of neonatal AKI in Neonatal Pathshala. We also like to felicitate Dr. Sheila Iyer ma'am and Dr. Next slide, please. Dr. Sheila Iyer ma'am and Dr. Jalpa Dave for being the faculty in today's case, and we also will present a certificate of appreciation to Kishan for presenting the case presentation of neonatal AKI. So thank you so much, and see you soon next Wednesday in Journal Reading Club. Same time, same link.